Hello, now in addition to the cervical anatomy review, we're going to talk a little bit about the thoracic spine. And I went ahead and I'm going to go ahead and do the entire thoracic spine PowerPoint in this anatomy review because there's only a few things that we're really going to talk about arthrokinematically. So I'm going to just include those here, but let me know in class if you have any questions. Okay, so the thoracic spine consists of 12 vertebrae with long spinous processes. So they're a little bit different than the cervical and obviously different than the lumbar as well. This question, what do we know about the alignment of the thoracic spinous processes and how they line up with the vertebral body? I think we know that the spinous process of the thoracic vertebrae are usually one, possibly two levels lower than the body of that same thoracic vertebra. The joints of the thoracic spine are synovial planar. Their capsular pattern is lateral flexion and rotation are equally limited, but both limited more than extension. The facet joint orientation is 60 degrees from horizontal, so most of the function of the thoracic spine is in that frontal plane, which allows us to laterally bend or laterally flex. Okay. Rib articulations. Ribs 1 through 10 articulate with the thoracic vertebrae through costovertebral joints and costotransverse joints. So here on the vertebral body is where that rib articulates, and then also on the transverse process, that's the costotransverse joint right here. I think we'll get a close-up in the next slide. Ribs 1 through 7 are considered true ribs because they attach directly to the sternum through the costal cartilage. Ribs 8 through 10 are false ribs because they do not have their own costal cartilage to the sternum, but they actually join the costal cartilage of ribs 1 through 7 of the true ribs. And then ribs 11 and 12 are floating ribs. They will articulate only with vertebral bodies. They don't have an articulation anteriorly. Okay, so here is the landmarks of a thoracic vertebra. You have your vertebral body. These are demifacets, which means that those ribs articulate with two vertebral bodies at the same time. So there's a inferior demifacet of the superior thoracic vertebrae, and then there's your superior demifacet of the inferior thoracic vertebra. Okay, there's your facet for the articulation with the tubercle of the rib, transverse process, spinous process, and here it shows the rib attached with your costotransverse joint and the costovertebral joint here. Prime movers for thoracic flexion are your rectus abdominis, your external obliques, and your internal obliques, because of course those obliques are working bilaterally for thoracic flexion. Thoracic extension, your prime movers are going to be your erector spinae group, your transversospinalis, and your interspinalis, which we showed some pictures of in the cervical anatomy review. Lateral flexion, your quadratus lumborum, your obliques, this is when they work unilaterally, and your intertransversarii, which will be also contraction on the same side. Thoracic rotation is created by the transversospinalis group and the unilaterally internal and external oblique. Okay, I'm going to talk a little bit about respiration. And respiration, you're going to see conflicting things for which muscles are primary movers for inspiration and exhalation, depending on what you read. So, but in general, inhalation, your rib cage is going to move up and out and increases that medial and lateral diameter. So it kind of billows out to the side. Exhalation, your rib cage is going to move down and in, and it decreases that diameter. So there's the movement of the thorax during respiration is elevation, depression, like we just talked about in the previous slide. There's a buckle handle movement and a pump handle movement. So laterally, the bucket handle, okay, comes up just like this bucket handle. So laterally out to the side here, the pump handle, which is this handle here, is more that AP, or superior and anterior movement, where you'll see the sternum rise anteriorly. Okay, so different phases and the muscles involved with respiration. With quiet inspiration, you're going to use the diaphragm, external intercostal muscles. So deep inspiration, where you're trying to get your air down lower into your lungs, you're going to be using any muscles that will tend to pull the ribs upward. So you're going to use your SCM, your scalenes, your pec major. Now forced inspiration, when you're trying to take a really deep breath very forcefully, these are also muscles that pull the ribs upward, but also muscles that stabilize and elevate the entire shoulder girdle. So it's going to include the muscles above, plus the levator scapula, upper trap, rhomboids, and pec minor. Expiration, quiet expiration, should just be a passive action. The muscles, your diaphragm, your intercostals will relax, but it shouldn't take any active contraction to make those relax. Force expiration, now you're looking at muscles that pull down the ribs. Okay, inspiration was muscles that pull up the ribs. So these are going to be muscles that pull down the ribs as well as compress the abdomen. So you're looking at your intercostals, rectus abdominis, your obliques, quadratus lumborum, and your transverse abdominis. And then we have origins and insertions of your muscles of respiration. So your diaphragm comes from your xiphoid process to your central tendon. Its action is inspiration, innervated by the phrenic nerve. So, yeah, it says here, it's shaped kind of like a parachute. Okay, and external intercostals, okay, these run, the fibers run inferior and medially. You'll see that here. And they basically go from the rib below, or rib above, to the rib below. They elevate the ribs and innervated by the intercostal. The internal intercostals will go from the rib below, superior medially, to the rib above. Depresses the ribs, but also innervated by the intercostal nerve. So accessory muscles of inspiration. I think this is probably where you get the most variety, depending on what you read. So you've got to remember, too, that these muscles can pull, they can actually perform the reversal of muscle action. So it'll pull the origin towards the insertion. So rather than, like the SCM, rather than flexing the head, if the head is stable, it'll pull the rib cage superiorly to allow that forced inhalation. So it works both ways here. Other muscles that pull down the rib cage would be the rectus abdominis. So rather than flexing the trunk, if the trunk stayed stable, it would pull the sternum down towards the pubis. Different types of breathing, and we'll cover this definitely more when we do pulmonary in special topics 5th semester, but diaphragmatic breathing, you're looking at using that diaphragm the most efficiently and effectively that the patient can use it. So you're looking at kind of the deep breathing, trying to use their lower lungs. Chest breathing, you'll often see chest breathing in different pulmonary conditions like COPD, emphysema, where you'll see more of that kind of pump handle breathing in that upper chest. It's not very efficient. It usually takes a lot of effort, and you don't get a lot of air in your lungs that way. Valsalva maneuver, you guys are familiar with this. This is when people hold their breath and are forcefully straining. You just have to be really careful with those people that have any sort of a cardiac condition. Different pathologies that you may see in the thoracic area. A stitch, also known, I think, more commonly as a side ache, is usually where you have a cramp in the diaphragm. It has to do with the fluid and actually lack of fluid, where the diaphragm, the muscle itself, will actually cramp. A rib separation is considered a displacement between the rib and the costocartilage. A rib dislocation is displacement of the costocartilage from the sternum. So dislocation, the rib and the cartilage are dislocated from the sternum. A separation is just between the rib and the cartilage. Okay, thanks for listening. That's all on your thoracic anatomy. Bye.